Hey crew, welcome to the MMOA podcast. My name is Shelby Blankenship. I am a physical therapist and one of your TAs in L2 as well as live. And today we're going to be talking about ICU deconditioning post cervical spine surgery in the outpatient setting. So this is a case study for a patient that I am currently seeing. And one of the biggest things that I think is super interesting to see is progressions of people, especially if you are more isolated into setting versus another. So I used to work in acute care, did a lot of acute care things for about 4.5, 5 years, and now I'm in the outpatient side, and it's cool to kind of see the transformation of a human from the ICU all the way out into outpatient. Now with this patient, they had a cervical spine surgery, specifically trying to just do an outpatient disc repair that ultimately went basically catastrophic. There was some things that happened during the surgery and then ultimately post-op that led to this patient being admitted to the ICU, had to be put on a ventilator, coded multiple times, and unfortunately had to be in the hospital for about 8 months. Eventually was transitioned from the acute setting into an inpatient rehab, and then eventually transferred from an inpatient rehab setting to home and kind of went from there. This transition period, when they went from inpatient rehab to the home, they were wheelchair/power chair bound, in that they were unable to ambulate by themselves and were so deconditioned that they had lost up to 100 pounds from their initial admission to the ICU. So as we know, this can lead to, so much limitations physical capacity, but he also lost capacity to intake food and end up having to be on a feeding tube and is still on that at this point. And what's interesting about this is we kind of see the transition of being so limited from a muscle mass standpoint, but also from a food intake standpoint, and how that can ultimately impact the quality of life and just overall lifestyle that this patient can do. And so when they started coming to see me, we did the SPBB, which we go over extensively in live if you haven't done it, but his score was a 4 out of 12. If you're not familiar with the scoring of the way the SPBB is, it's basically like a screen of doing balance, gait, and a 5 times sit to stand, but it's not exactly a 5 times sit to stand if you know that caveat. And what's interesting is his score was dramatically low. Usually between 8 to 10 is where we're considering like this is a high fall risk and we've got some concerns and things that we need to address. So 4 out of 12 is what he started with. His biggest limitations were he was unable to do a sit to stand completely by himself without using his upper extremities, and his gait speed was extremely slow. But he was ambulatory when he came into the clinic. History of multiple falls after all of this had happened with ICU. He just really struggled with dragging his feet and lack of endurance and all those kinds of things. So after we did the SPBB, we also looked at things like his vitals. And one of the things that we noticed, not only on initial eval, but as we started to see him through treatment, is he really struggled with dizziness and orthostatic hypotension. His normal blood pressure would probably start around like 110 over 60, and he would drop into the 90s or 80s over 50 or 60 by the end of session. So especially with his limited intake, because of him having to use a feeding tube, and he was not able to do things like water or ice chips or any of that at this time, we were having to kind of do alternative modes to kind of get his blood pressure in a better range. He is a very tall individual, and that also kind of plays a factor, but he talked to his doctor and was able to take a medication to increase his resting blood pressure. So now we're at a point where he's doing more of like the 140s to start out, and he still drops, but he usually stays more into the like 115s, 120s. So it's not as symptomatic. He's not feeling super crappy and all that kind of good stuff. So those are the big things that we have been monitoring as far as objective measures. Now, as far as treatment goes, he's, like we talked about, his sit to stand was super, super limited. So we started him on a 24-inch box, just trying to see what was the height that he could do an actual sit to stand without using his upper extremities. And that was the good height for him to start at. And then as we were able to, we used rings and got to a lower box. So we would have like this happy medium of using no hands, kind of working more on like the strength base, and then working on depth using our rings or handheld assist to kind of help with depth. We kind of started mirroring those two kind of coming together, where we would lower the box height with no upper extremities and then sometimes use a higher box and started adding weight. What we found is that he actually does better when he has weight in his hands to kind of counterbalance him when he's doing his sit to stands versus no weight. And you'll kind of find that sometimes where some people struggle more when they have no weight to kind of like get that leverage up. And so don't be afraid to load your people early, even if they struggle with no upper extremity assist, just to kind of see what they do. And if anything, just do it on the eccentric portion of the sit to stand. And then another thing that we really wanted to focus on is deadlifts and farmer's carries. He is somebody who has to do a lot of carrying around at the house. They have a lot of dogs. They have to manage a lot of dog food and all kinds of items for those pups. And that capacity of bending forward and back was something we were kind of monitoring with the blood pressure. So we were having to start in a lower range of motion. And then as he's gotten more acclimated to his blood pressure is getting in a good range and his overall strength, we've been able to increase range of motion and overall increase load. We started with 5 pounds in each hand is where we started, and he got up to 26 pounds on each hand currently. So that's over about a 3-month span. So it's definitely doable. You just kind of have to tailor it to that patient and how they're feeling that day. When it came to gait, his speed was very, very limited. So the biggest thing that we did to kind of propel not only his gait capacity, but also his turnover and cadence was using our sled. So we have a sled that has upper extremity positioning. So it almost looks like a reindeer. And we were doing push and pull. So he would push down and then he would pull back, working on that backwards gait to kind of get a different positioning for his feet, work on some more stepping strategies, but also get some glute extension because his hamstrings and getting fully upright is very limited for him. As he's progressed, he's been able to not only do the sled push and pull with less contact guard or min assist, but now he's able to sled push down with the uppers and then sled push back with a lower position. So he's actually able to get in a more horizontal position when he's doing the sled, which is awesome. We've also added in doing things like jogging. I know you're like, who's jogging? These people need to jog. If they are struggling with gait speed, this is an area where you can kind of get a little oomph behind them, because there is no problem in being able to not, you have to be able to know how to run away from a bear or a quick car coming by. And so we would practice intervals where we would do maybe like the 8-meter gait length. And then we would do intervals of like where he would jog one way and then walk back, and trying to slowly time him and get his increase in speed so that he was aware. Sometimes people just lack awareness that they're moving that slow. And especially when they're so fearful of falling, or balance is a component that you're concerned about, we need to make sure that we are creating a safe environment for them to do it in, but like encouraging them like, hey, if you're walking this slow or you're not able to react fast enough, that actually is going to lead to more falls. So we need to get you quicker at doing things. The last 2 pieces that I thought were super important for this patient is his sit-up and his seated hip march capacity. He talked a lot about being really limited and getting like shoes and socks on or his pants on, and like that reaching capacity with being able to lift his leg. And what I found is when he was doing like a seated position, he looked great because he was sneakily using his upper extremities for that bracing. But if he was having to do a hip march and not use his hands to brace, he was severely limited. And especially when you think about people who have feeding tubes, they're very concerned and guarded in that area because they don't want things to get messed up or things to pop out. And especially if you've ever been around feeding tubes quite a bit, they can have their complications as far as just positioning and comfort level. And so we have been working on like seated hip marches where he's in a taller seat. So instead of maybe like an 18-inch chair, we'll do a 24-inch or a 20-inch. And that way he's got a little bit more hip extension and then has more range of motion to do that nice hip march. And then we've even gone into doing a banded assisted sit-up. So I'll use like a long bench. If you've ever done the pelvic live course, they do a really nice job of kind of going through these modifications. and you'll wrap a band around the rig or whatever you have, and then you use that and kind of do like a stair step down and a stair step up. You can use wedges or pillows to kind of limit the range of motion, especially if dizziness or just overall limitation in capacity is there. So those are some options that I really like, and it helps them be able to get in and out of bed better. It helps them be able to get dressed easier. That midline is just one of those areas that we tend to neglect a lot because we just assume like all they care about is walking. Well, they got to be able to get out of bed first, right? Like that's super, super important. So just to kind of recap of what we've done with this patient: started in ICU, severely got deconditioned, was there for 8 months, and ultimately having to be on feeding tubes and lost 100 pounds, super kind of sucky situation. And now we're 4 years post, and we've created a more robust human. He went from being in a power chair to on his own being able to walk into our outpatient clinic. When I first started seeing him, he got an SPBB of a 4 out of 12. And when I just tested him about a week ago, he got an 8 out of 12. And so, you think about the SPBB, like 1 point is clinically significant. So we've seen a lot of good trajectory on how much capacity he has. And not only is that great for us to see, but it's great for the patients to see how much progress they can make in a short amount of time when they really put forth that effort. The other option and thing that you want to make sure you're looking at for objective measures is those vitals. We want to make sure we're monitoring that, especially when intake is very limited and hypotension, orthostatics are something that you're having to kind of be aware of. So definitely make sure you're monitoring that. If they cannot change their like water intake or anything like that because of a feeding tube, having those conversations with the doctor and seeing what opportunities for medication are available to kind of help keep that human more functionally active, especially not just in session, but just in daily life. As far as next courses coming up, L1, we are going to be May 20th is when we start up. L2, we will be starting up September 16th. And then as far as live goes, we have a couple courses coming up this weekend, April 25th, Kansas City, Missouri, and Portland, Oregon. And then the next weekend, we will be in Bend, Oregon, and Minneapolis, Minnesota. So hopefully this was helpful for you, especially if you easily get discouraged when it comes to seeing your patient only in one setting and not sure what their trajectory can be. Just know that you're putting forth the effort, keep doing it, and hopefully we'll see you guys in a class sometime soon.